Good morning, students. Today we are going to talk about the care of the postpartum patient. Postpartum is defined as the period of time in between the birth of the baby and the return of the maternal organs to the pre-pregnancy state. Our goal here is to monitor the repositioning of anatomical organs and the return of her ovulation and menstrual cycle. It is important to note timing is absolutely critical in OB. What is expected finding at one period is not expected later. What we see are many physiological changes and it impacts our nursing care. This slide is just to outline some of the topics that we're going to talk about today, and your textbook actually does a really good job of outlining a postpartum focused assessment. I would recommend that you refer to your textbook. One of the most important reproductive changes that needs to occur, is uterine involution. So, what is involution? Involution is the natural process by which the uterus returns to the pre-pregnancy state through natural oxytocin letdown. Now, that letdown causes uterine contractions and vasoconstriction. Fundus assessment, which is the top of the uterus, should be done after breastfeeding or after voiding. We are assessing for three things. We're looking for tone. Is the uterus firm or boggy? We're looking for position. Is it midline or deviated? We're also looking for height. Where is the top of the fundus as it is compared to the patient's umbilicus? Patients need to be instructed that they will experience after pains from the uterine contractions related to involution. And this is a good thing. We want this to occur. After pains can increase with breastfeeding due to increased oxytocin letdown. The contractions also increase with multiple pregnancies and with an overdistended uterus. Lochia is a menstrual-like flow that occurs after childbirth. It consists of blood and decidual debris, and it originates at the vascular placental site inside the uterus. After birth, controlling bleeding is achieved by reduction of the placental site after birth and the vascular constriction of that site. In terms of assessment, first assess the bladder and assess again after breastfeeding. And we're looking for bleeding both on the perineal pad and under the patient on the blue pad. Normal progression of lochia should be rubra to serosa to alba. Expected findings include lochia flow like a heavy period in the first 2 to 4 hours. The lochia should always smell fleshy and never foul. Bleeding will increase with activity, breastfeeding, and a multiparous patient. Patients may experience a large gush of fluid with first ambulation secondary to pooling, so we need to make sure to warn the patient before we get them up for the first time. That can be kind of scary. Less bleeding is expected with a section because the doctor may clean out the interior of the uterus. I like this slide. I believe in love at first sight because I love my mom since I opened my eyes. Keep in mind, though, that uterine discharge does not always have to be lochial flow. If there continues to be a bloody discharge that is maybe a little bit redder in color and the fundus is firm and midline, this type of vaginal bleeding is considered to be non-lochial and can be associated with cervical lacerations. Okay, as you could expect, assessment of the perineum is most important. To correctly inspect it, it is best if the patient is in the lateral Sims position and use a light to complete your assessment. An episiotomy may or not have been done, and it is a surgical incision done on the perineum to allow more room for birth. As a part of that episiotomy, there may be lacerations or extensions to the epies. They come in degrees. The first degree extends just through the skin. The second degree extends through the skin and the perineal muscles. The third degree extends through the skin, muscles, and anal sphincter. The fourth degree, most traumatic, extends through the skin, muscles, sphincter, and rectal wall. We may also see hemorrhoids, which are very common. In most cases, they're just treated with over the counter medications. Patients should use ice for the first 24 hours to reduce swelling and anti-hemorrhoidal cream and ointment as prescribed. Stool softeners are highly suggested. Teaching prevention includes, with a fourth degree, nothing rectally. Also, change the pad with each void or stool, good hand washing, teach the patient good hygiene, such as wiping from front to back, teach the patient the use of ice packs for the first 24 hours, sitz bath after that, and the use of the squeeze peri bottle every time they go to the bathroom. Anesthetic sprays such as a lidocaine spray and Tux pads are encouraged for comfort. RITA is a tool used to assess episiotomy or any wound for that matter. It stands for R is redness, E is edema, E is ecchymosis, D is discharge and drainage, and A is for approximation. Let's talk a little bit about hormonal and GI changes. The hormonal changes that occur during postpartum can be profound and affect the woman both physically and emotionally. What we see is after birth, estrogen and progesterone levels drop significantly while prolactin levels increase. Prolactin is responsible for milk production in postpartum women. In non-nursing mothers, there is a decrease in prolactin levels, which in turn results in early ovulation and return of the menstrual flow within 27 to 75 days postpartum. In nursing mothers, prolactin levels are increased, causing ovulation to occur later, and the menstrual cycle returns later, somewhere between 3 and 6 months. Keep in mind that prolactin levels are influenced by frequency and length of feedings and the amounts of supplementation. Women should be taught that they may ovulate without menstruation, so should be advised not to use breastfeeding as a form of contraception. The patient's gastrointestinal system should also be assessed. Nursing assessment also includes listening to the bowel sounds, checking for flatus, and monitoring bowel movements. Hunger is a normal postpartum or post-delivery phenomenon. Constipation, of course, is quite common due to decreased muscle tone and dehydration, also due to pre-labor diarrhea, fear and lack of food, and decreased peristalsis. Teaching should encourage early ambulation, including roughage, increased fluid, and possibly a stool softener. If this is the woman's first pregnancy, the abdominal wall muscles will separate and protrude. This is called diastasis recti abdominis. Don't you just love those Latin words? Let's look at the patient's urinary changes. The postpartum woman's urinary system can also experience some significant changes. The nurse should assess the quantity and frequency of voiding. It is quite common to find the perineum swollen after birth, causing edema that can occlude the urethra. If the bladder is full, the nurse would assess a spongy feeling over the symphysis. Women are at risk for UTI due to dilation of the urinary tract and small, frequent voiding, which encourages bacterial growth. Since the client is at risk for orthostatic hypotension due to blood pooling, the nurse should assist the client to the bathroom first void. Catheterizing is done only as a last result. Expected findings include mild proteinuria due to decreased placental mass breakdown, voiding reflex altered, urinary retention due to trauma, as mentioned before. The urethra can often be bruised and edematous, and anesthesia, discomfort, and episiotomy. Diuresis occurs first 12 to 24 hours. Commonly, patients have decreased voiding with normal increased diuresis, increasing their risk for a distended bladder, which also increases risk for hemorrhage due to subinvolution. Okay, let's take a look at the breast care for a lactating mom. If we review the physiology of breast milk, we know that prolactin is responsible for milk production, and oxytocin is responsible for milk letdown. It also causes afterbirth pains. Part of our patient education should include the benefits of afterbirth pains and how it helps to contract the uterus down to its normal size and impedes bleeding. There are some common problems and interventions associated with breastfeeding. Our assessment should include inspecting the areola tissue for trauma, which is usually due to poor breastfeeding positioning. Colostrum is present initially, which is commonly referred to as foremilk, and is pale yellow in color. About day 3 or so, white milk or hind milk comes in. Breast becomes more full and firm, and this is often associated with a low grade temperature. Maternal nutritional requirements are somewhere between 2,500 and 2,700 calories per day, and at that, moms still lose weight. Education for success includes to teach the mom to massage her breast before feedings. This will assist with the baby latching appropriately and prevent tissue trauma. Begin feeding with the breast last fed on to ensure proper emptying, which will prevent a plugged duct. Inverted nipples or flat nipples moms can wear shells to improve that. Lanolin is used for soreness. The patient should be taught to wear a well-fitted supportive bra. Engorgement may occur, breasts become uncomfortable and firm. This engorgement can occur somewhere between day 3 and 4, and that's congestion of the venous and lymphatic circulation. Patient teaching for engorgement includes applying warm compress, then feeding every 2 hours. Breastfeeding contraindications include an HIV positive mother, systemic illness of mother like active TB, maternal meds like chemo, and mother's aversion to breastfeeding. Okay, let's talk a little bit about maternal changes with regard to respirations and neurological involvement. A couple of things that we see here. After birth, there is a decrease in intra-abdominal pressure and the diaphragm drops, making respirations easier. Cardiac access is restored. Neurological issues such as carpal tunnel and headache caused by preeclampsia are now medications. These are often given in the postpartum period. Medications commonly administered start with rubella vaccine. It's given to the non-immune patient for discharge. Before discharge. It is a sub-Q injection given for the next pregnancy. It is important to administer if the mother is non-immune because if the woman contracts rubella during the next pregnancy, the baby may be born with anomalies. A couple of things to note. The woman should not get pregnant for 3 more months, and it is typically not given with RhoGAM. Speaking about RhoGAM is given to an Rh negative mother at 28 weeks and after a normal delivery of an Rh positive newborn. Also given after any invasive procedure, including a miscarriage. It's also given after a motor vehicle accident. The lab test that's used is called the Klein-Hauer-Betke blood test. We will talk about these again in newborn care. Both Tux and Dermaplast spray are over-the-counter perineal comfort aids that are encouraged. Tux are witch hazel pads and Dermaplast is a lidocaine spray. Iron supplements for decreased hemoglobin are also encouraged. They may cause a dark stool and also constipation. So we need to teach the patient to increase her fiber and water. The last thing, they may recommend stool softeners such as Colace and Senokot. Narcotics and NSAIDs are given for general malaise and discomfort post-delivery. All right, I guess that's it for Chapter 18. Hope it was helpful. Thanks. Bye.